having our chief residents give their end-of-the-year presentation, and today is our chief resident in cardiothoracic, Amir Sarkeshik, who is a native of California, did his undergraduate here at UC Davis before he went off for his medical training, and then came back to us as a integrated resident in our I6 program in the cardiothoracic residency here. We, as you can see, he's got a relatively provocative topic there. And just as a reminder, since there are some rules and university regulations around, quote, political conversation, that none of these are the opinions of the university, or as we do, as we say when our military colleagues give presentations, do not represent the federal government, etc. But the point is, we very specifically give our chief residents the opportunity to talk about whatever they want. And I do think, and I'm looking forward to looking through his background. Amir has a lot of experience in working with the AMA and participating in the political science activities in his previous life, bringing him up to here. So I suspect we'll have some trails about that. Also, and hopefully an announcement about what your plans are after finishing training here relatively shortly.
Before I rock the coat or after?
Wherever that fits the best for you, because I know lots of your friends and colleagues are interested in your plans. So with that, Amir, we look forward to and welcome and congratulations on reaching this stage.
Thank you.
All right, so the topic for today is surgery as a political act. Sounds provocative, but as you'll find, it's actually a lot less provocative than it sounds. There's no financial disclosures, and nothing that I say today reflects the views of the university, the Society of Thoracic Surgeons, American College of Surgeons, or ABC family. So the purpose of today's talk is hopefully I can sort of rock the boat a little bit, not to sink it, but to hopefully shift the tides so our ship sails forward in our field and specialty, because I feel like we're in a state of sort of stagnancy and stagnant sort of behavior. And I'll sort of start with this quote by Rudolf Virchow. Everyone knows him, right, from the triad, but very few know about his political and social involvement and background. And this quote says, "Medicine is a social science, and politics is nothing more than medicine on a larger scale." As a matter of fact, it's a very timely quote because this month is going to mark the anniversary of the Great Sausage Duel of 1865. I don't know how many of you know about that, but essentially Virchow was so heavily involved in the political arena of Germany, or Prussia at that time, that the president of Germany challenged him to a duel, and he was allowed to pick his own weapon. So he picked two sausages. One of them had cholera, it was infected with it, and the other one was free of it. And he told the president, you can pick whichever one you want. They didn't pick, and the duel never happened, but it sort of marked his name in history as sort of this clever physician politician. And he actually started his own party as well. So having said that, let's establish that as sort of a core principle. And this is not new, by the way. This sort of dates back thousands of years. If you go to Avicenna and the older physicians, the canon of medicine, a lot of it sort of reflects the same behavior of medical, social, and political involvement being intertwined with one another. So in order to understand that, I want everyone in the room to sort of rewind their clocks all the way back to your undergraduate or high school, whenever you first thought about wanting to become a doctor, a PA, a nurse practitioner, a nurse, and what your intentions were. Was it anything outside of helping another human being? Was it anything outside of that sense of altruism or giving someone else, a helping hand? What motivated you? And I'm willing to bet, at least on your personal statements, that's what you said, for most of you, because that's why you're here. And I'm willing to bet that most of you are here because of you truly inherently believe that as well. So, here we have hundreds, if not thousands, of people that want to get into medicine in the medical field, whichever specialty you want to go into, but only a select few make it to the racetrack because of organic chemistry or biochemistry or whatever. Everyone remembers that. And then even a smaller sample finally make it to the finish line, right? And this is the general public kind of confused why we're like just hemorrhaging money and competing to get into medical school. Finally, we go through medical school. I'll do that again because it took me a little bit of time to make it. Right? And the general public is looking up to us right now as sort of the flag bearers of medicine, the medical profession. And we have even more people that are confused about what we're doing. They're like, why do you have $300,000 of loans? Or, why aren't you there with your family? Do you have a family? Where did your 20s and 30s go? You haven't bought Bitcoin? Student loan? What's that? Oh my God! Everyone's kind of, they're genuinely concerned. I still have extended family members that don't understand what residency and medical training entails, unfortunately. But you go into this profession ultimately to profess. If you look at the sort of the ideology of the word profession, it roots back to professing something, and professing something in its root means to make a public declaration, to make a public testament, to make a public creed or decree that you're going to do something. And what's our public decree? What's our testament? Many of us just graduate, put our heads down, and we follow the trails of individuals that sort of led the path, but we don't question the terrain. We don't question the path. We don't question the weather. But our role, in essence, is sort of defined by that. It's defined by making this sort of outcry and professing for those you advocate for, which are ultimately your patients, who are considered by society as the most vulnerable people, right? So what happened? So, like I was saying, profession's more than just a job, right? Or a career. It's sort of a calling. I'm talking about the medical profession. I'm not talking about like working in and out or whatever. It implies this devotion, right, to this vocation. But how do we manage that, and how do we navigate that in a world that has so much external regulatory sort of markers and inhibitions and restrictions, where we make this public testament, the Hippocratic Oath, it's a public testament to look after our patients, to do what's right, to do what's morally and medically necessary, but then we face regulations by insurance companies, Medicare, hospital administrations who don't want to keep the patient in the ICU or want to discharge them, and so on and so forth, or patients are poor rehab candidates, So what happened to our mantra of medicine? Is it now just defined by RVUs? And how do we sort of navigate those challenges on a day-to-day basis? Because it's going to ultimately eat up our core of, altruism, etc., of why we went into medicine. So that leads us into advocacy, right? Whenever I say advocacy, everyone assumes that it's sort of partisan politics. I don't get involved in politics. I don't talk about politics at work. It's provocative. It's not partisan politics. It's not party politics. Advocacy just means advocating, professing for your patients, for your profession, for your field of medicine, for your colleagues, for your hospital, for your community. So why should you be involved? Sorry, a little dry. So it doesn't, it's not appealing. I went, as Dr. Farm mentioned, I was a double major in undergrad. I did political science as well as neurobiology because I couldn't make up my mind. I went and worked in the state capital for a year with Assemblymember De Leon. And after a year of trying to essentially make a park for the poor district in the Hollywood region, Arnold Schwarzenegger just comes in, vetoes all the bills, doesn't read them, and it's on to the next fiscal year. And I was like, I can't do this. I don't have the patience for it. At the same time, parallel to this, I was working in the ORs, the old ORs here. I was essentially, I think it was OR Tech 2 at that time, where you turn the rooms over, you mop the floor, you get things going. Better turnaround times back then, I can tell you that. But it sort of made me appreciate this sort of sense of urgency this sense of urgency to do something because you got to get the patient in. There's another patient coming. There's the ER's full, and that sense of urgency sort of trickles down to everyone, all the way down to me, who was like an undergrad, OR tech too. So that sort of dichotomy between politics and medicine is what drove me ultimately into medicine, and especially the field of surgery. So why should people be involved? Again, it's not appealing, but it's going to affect you, right? And if you don't make these decisions, if you're not involved, someone else is going to talk for you. There's greater lobbying powers, they're going to talk on your behalf, and someone else is going to get your piece of the pie. So, there's no, even though I have a background in politics, doesn't mean you guys have to have a background in politics or anyone needs to have it. It's just, just showing interest and sort of advocating for your specialty. So again, you don't have to be highly informed. How you start is you identify an issue within your field, something that's affecting you, your patients, your hospital, your colleagues. You plan and recruit people, you mobilize them, you do advocacy efforts that I'll go over, and then you finally sort of roll it into legislative action. And hopefully, after 2 decades, it'll become some sort of policy and trickle down. And to sort of reflect on this, it sounds all nice and dandy. I'm going to go through a few legislative wins that we've had to show how it's affected you guys and sort of everyone. But a lot of people don't know about these. So these are some of the ones that, as you can see, I'm not going to read through all of them, but TAVR coverage determinations. Lung cancer screening coverage was a big one in our specialty. Reverse damaging ECMO payment reductions that were supposed to happen last year. And the 8% cut in essentially CT surgery payments, as well as vascular surgery, as well as general surgery, and neurosurgery payments. And the addition of 1,000 new Medicare-supported GME spots for residents. So I'm going to go through a few of them and show how these small legislative wins have such a strong and large impact in the greater public health and the health of our patients. Lung cancer screening. So just a quick, I don't want to get into the nitty-gritty of it, but as everyone knows, lung cancer survival rates are not very high. It's 56% in patients that are caught early, but the caveat is only 16% are caught early. And in comparison, prostate cancer, it's about 98% currently 5-year survival. Breast cancer is at 90%, and pancreatic cancer, unfortunately, still remains low, somewhere between 6 and 8%. Again, if it's caught early. So again, the problem with lung cancer is by the time it becomes symptomatic, it's already spread, and at that time your survival is very low. So we're trying to identify the perfect screening time for patients where they don't have clinical symptomatology, but it's radiographically present, and we're able to capture it, so we can detect those patients and treat them. As you can see, again, localized, only 16% are caught. And out of those, the 5-year survival is about 56%. In comparison, if it's already spread, to distant, the 5-year survival drops down to 4%. So significant reduction. So again, this was essentially based off of the lung cancer screening trial. That ultimately, this essentially just echoes what I was just telling you. But what we're trying to do is find this perfect sort of sweet spot where you can screen patients, and the screening trial that I was just talking about sort of defined that for us. But we took that to legislation, we took that to Congress, and ultimately in 2015, Medicare approved payments for low-dose CT scanning in patients with certain criteria based on the inclusion criteria of that study. So they have to fit within that range group. They have to have smoking history, et cetera, et cetera. But the point being, I don't want to go into the nitty-gritty of this. The point of this was now thousands, if not millions, of people are going to benefit from this down the line. Now we're seeing more and more people that are getting referred to us with early-stage lung cancer that's getting resected and ultimately treated. Whereas these patients would have, by the time they would have been symptomatic, it would have been unfortunately too late. So this is an example of being involved in legislation and having a high impact, essentially, on your patient population and your field, right? The second one that I was actually involved in 2019 was banning smoking at VA facilities. It sort of baffled me that up until that time, there are still indoor smoking areas at VA facilities. 15 VA facilities in the country have smoking booths inside. It seems sort of archaic, right? And almost 1,000 of them have outdoor smoking areas. That's in a world where all the academic centers, all the private hospitals are, very strict, essentially, no smoking zones. And in the setting of having, our veterans being more essentially vulnerable to lung cancer, up to 25% more. And I went through the history of it. Interestingly enough, this bill banning smoking at VA facilities has been fought since the 1990s. And it sounds crazy, right? But I think the group was called Lobbying for the Freedom of Veterans or something. And they're the ones that were essentially advocating for allowing veterans to smoke inside of VA facilities. And this is an ad from like 1996. I don't know what paper this is from, but essentially depicted like a poor veteran in the parking lot, saying if you take away these smoking areas, then they're just going to go in the parking lot and I'm assuming his face was sad or something, so to sort of influence public behavior and vote. And this battle has been going on since the 1990s, and finally recently this changed. So again, this is from 1992 Washington Post that I got from the archives of UCSF. But again, it just shows how this debate has been ongoing. And when I was talking to some of our legislative sort of steering committee members about this topic, I actually called them to see, why, because I never realized this has been an ongoing battle since the 90s. Why is it delayed so much? A lot of it was public opinion. The public opinion about smoking has significantly changed since the 1990s, and our understanding of essentially the direct correlation between smoking and lung cancer has increased as well. So, that obviously influenced it, but ultimately it was, the momentum was accelerated with the sort of political action committees of our societies. And finally, we took this to Washington. I actually made this YouTube video. You can't really see, but it says it's from an accredited healthcare educator. I don't know how YouTube determined that, but I guess I am. So we made this, and we took this to Washington. We spoke with all the major, essentially, legislators that were involved with the bill, or the ones that were sort of on the fence, and ultimately, as you can see, they began October 1st of 2019 to ban them across the board. So again, advocacy impact. Our VA patients, COPD, 25% increased chance of lung cancer. Take it to Congress. Because can you imagine? For this many years, we're essentially giving substandard care to the people who we claim, served our country and are supposed to get a better treatment, and we're actually giving them worse treatment, right? So it's sort of baffling for me. So then it takes us sort of to the next chapter, advocacy in the COVID-19 era, because this is very foretelling, and it sort of unmasks the importance of our advocacy groups during COVID. As we know from China and Europe and some of the other Asian countries that were affected early on, there was a major supply chain shortage with everything: ventilators, tubes, oxygenators for our ECMO circuits, as you guys know. And so our advocacy groups sort of jumped on it early. As soon as they saw that, this is affecting Italy, China, France, they literally picked up the phone and got in touch with their contacts in the Department of Human Health Services, Energy and Commerce, CDC, FDA, to see how we can, mitigate those shortages as soon as possible to get the equipment to us who are on the front lines providing care for our patients, right? As you guys remember, we're short on masks, etc. You can imagine if we don't have these people in the background doing this for us, how much worse it could have been. Okay, so this sort of unmasked the importance of being involved in sort of our political action committees. And another thing that sort of, I don't know how many people know this, but in the same setting of COVID, there was planned CMS cuts of not just CT surgeons, but vascular surgeons, general surgeons, and other surgical subspecialties by 8%. The reimbursement rates we're going to drop by 8% because of the whole budget neutrality concept, where they added new telehealth coding and they had to pay for that. And the best way to mitigate that was essentially to cut the people they thought were getting paid too much. So, advocacy doesn't end in COVID. We did it all virtual. And, out of desperation, comes inspiration and sort of development and inventions. So during COVID, as COVID numbers peaked and we're sort of on the fence of our, we're having this healthcare and economic crisis and everything was getting intertwined, the Surgical Care Coalition was formed, and the Society of Thoracic Surgeons, along with American College of Surgeons, were sort of the steering committee and founding members of it. But it also involves sort of the neurosurgeons, ENT, orthopedics, etc. And when I got down to the core of it, it was mainly because of the 8% cuts that they're all going to face, and they figured that if they make a collective voice, as one by forming this coalition, their voice is going to get heard. It's going to be louder. It's going to be amplified, and that's exactly what happened. And they made these cool little animations and clever metaphors. So what happened was, again, the CMS was in the calendar year of 2021 was trying to, through the Medicare physician fee schedule, cut cardiac surgery reimbursement rates, general surgery, thoracic, as well as vascular per the respective cuts. But through all these advocacy efforts and the creation of that coalition, which was instrumental, these payment cuts got stopped. And I think stopped is I would use a softer term. It's actually we kick the can to the next calendar year, essentially. So currently they're planning on doing a 2% cut on all across the board, and then in January it's going to be a net 10% cut of reimbursement. But at that time, the coalition has already said they're going to do they're going to play the same game, and it's going to keep getting the can is going to keep getting kicked down the road. Having said that, some insider news that I got, there are people in Congress that are now recognizing that this is a sort of an annual problem, and they're starting to change some of the policies and the verbiage to make sure this doesn't recur every year. But I don't anticipate it's going to be within the next 3 years. And when the payment cuts happen, these are the CT surgeons and vascular surgeons, they're all happy because they got their reimbursements. Advocacy is for everyone, right? It's not just for, as residents, who cares if they got cut 8%, right? But no, it affects everyone. Advocacy affects everyone. And the thing that affects us the most is this Resident Physician Shortage Reduction Act. I don't know how many of you know about it, but it's essentially, it affects us on a day-to-day basis, and I'll tell you why. As you know, and as you've experienced throughout your residency, or will experience throughout your residency, we like to use these terms like burnout. When people get tired, when they're overwhelmed, when they feel overworked. And it was interesting for me that all these major studies came out to define why burnout was happening and to sort of come up with reasons and explanations of why people were getting quote unquote burned out. And some of the things that they noted were, emotional intelligence, which is kind of offensive. And, maybe it's the traditional metric tests, the AppSide, USMLE, et cetera, MCAT, that are not measuring the emotional intelligence. Maybe we need to come up with a new test to sort of circumvent and mitigate this burnout. But no one really looked at the core cause of it. In 1997, the Balanced Budget Act essentially capped the number of residency spots that Medicare was going to fund. Okay, so it's been capped since 1996. In the same setting, doesn't take a rocket scientist, med school enrollment rates went up 30%. We have more hospitals around the country. With the Affordable Care Act being passed a few years ago, there's going to be an estimated influx of 32 million patients within the healthcare arena, and increase in 11% of the population within the next 10 years. Estimated. And also, a lot of these patients, about 40% of them are going to be older than 65, presuming, they're going to have more comorbidities and they're going to be more involved within the healthcare system or strain the healthcare system, as they say. Well, what does that lead to? It's going to lead to an overflow of medical students not matching because there's more medical students graduating, right? But the number of residency spots is capped. And it's going to lead ultimately to a shortage of physicians. And estimated by the American, so there's actually multiple studies that were done, but the estimated is about 50 to 150,000 doctors, across the board by 2033 shortage, including primary care, et cetera, and about 31,000 of those being in the surgical subspecialties. And what's crazy for me is this was sort of predicted in like 2001. There's articles by Bruce Lytle and all these other people like in Circulation, major journal, high impact journals, talking about this, how we're going to face this crisis in 2020 and 2030, and no one really listened. The papers are published, people probably like shrug their shoulders, and a lot of times as physicians, I think that's one of the things that we may share with the politicians is unless a fire is in front of us, we're not addressing it. And now with COVID, that fire really got unmasked because the strain went up on the healthcare system. There, generally across the board, New York Times had a survey of 1 in 5 physicians saying that they're going to leave the medical profession in the next 2 years after COVID because they feel so strained. And so these numbers are, arbitrary now because this is pre-COVID estimations. That's due to change, meaning the supply-demand, variation is going to grow. So again, it doesn't take a rocket scientist. You have a certain number of ice cubes. I like to use inanimate objects to teach my 6-year-old. You put the ice through a funnel, but ultimately there's only a certain number of spots in the ice cube tray. So what's going to happen to the rest of the medical students that are overflowing this and not getting matched into these? They're just going to melt away. So that's not to say you're not going to melt in residency, but at least you have a secured position. Okay, so this is a problem. This is a big problem. And so this Resident Physician Shortage Reduction Act has been essentially ongoing every fiscal year since the early 2000s. And finally, we reached some progress, but I'll go over that in a second. And these are some articles sort of echoing what I was saying. Thousands of doctors, they can't get a job, they're waiting tables, etc. In the same setting, you have places, this actually looks like West Sacramento, but I'm sure it's like Kansas or something. But they're in shortage of family doctors. I mean, this is crazy. And this is the article that I was talking about. This was actually published in like 2009, by in Circulation. And at that time, they're estimating that there's about less than 2 cardiothoracic surgeons per 100,000 population. And they're estimating that shortage is going to grow to about 1,500 by 2025. Scary. And that's, again, pre-COVID. After COVID, a lot of CT surgeons retired because they're, on the latter end of their career. So big problem. Again, this just sort of reflects what we're talking about. So this is a very recent win that we had. They sort of budged, and this got thrown into one of the major bills that came out of COVID. But essentially, we were able to secure 1,000 new GME slots within the upcoming fiscal year. But the language is very prescriptive. So it has to be in rural areas or regions where there's a shortage of physicians, or hospitals that weren't getting appropriate allocations for GMs. So I don't think we're going to get affected by it directly, but a lot of hospitals across the country, including medical students that weren't matching, are going to get affected. So this is going to lead to about 200 positions, I believe, annually, ultimately. So, when I was thinking about all this, I was like, why, because when we would go to Congress and talk to legislative staff members and even, Congress members, the language was very universal. They talked about burnout. This burnout language was very, and it's interesting for me because once you start talking about this and throwing the word out there, it becomes sort of a social, almost construct, and everyone sort of defines you by that. Why do we call it burnout? I mean, burnout, that sort of implies that you're not resilient, that you're going to burn out like a candle. I mean, if a candle burns out and you're out of the wax, can you light it up again? No. I mean, why don't we call it moral injury? Why don't we call it, overworked or overwhelmed? And I think this term burnout sort of entails that you're not adapting to the system or the conditions. And that kind of language can be essentially hurtful. So, this sort of leads to, in recent years, having one of the highest suicide rates out of any profession. And I think a lot of it has to do with the language that we use, because this language sets the expectations. And as type A individuals, someone can't tell you you're not resilient, right? it hurts. So, again, these are all just like, articles about this is a hospital in New York, NYU, the resident essentially jumped off their dorm roof. And if I remember correctly, there's like two of them happened within the same, John Hyde is nodding because he probably remembers, but two of them happened in the same year. And when I was looking at the paper, because the hospital and the state did an investigation, ultimately their finding was the stairway to the roof was not chained off. So the correction is we're going to chain it off. Case closed. So I mean that's kind of crazy. They're not addressing the underlying problem, and it's unfortunate, but it creates this sort of situation where these residents that committed suicide or are facing depression they get frustrated because people say you're burned out. Go do yoga. We're going to hire a wellness officer. They're going to talk to you about mitigating your time and practicing breathing exercises. And I'm not saying that's bad. Those are all good. But it's not addressing the underlying problem. And that has to do with the language, right? And, then they get more frustrated. Then they say, yeah, you're definitely burned out. You need to take time off or something. And no one really defines it as moral injury. Interestingly enough, we use military metaphors all the time, right, in our language. We're on the front lines of care. We're fighting a fight against cancer, the battle against COVID-19. Yet, when we get injured, we try to brush it off as burnout. You soldier, you're not made for this. You're not resilient. You weren't cut out for this. Whereas in the military, they call it PTSD. They call it actual, medical terminology. They use medical terminology. But in healthcare, we use terms that are almost derogatory or brush off the inherent problem. So why don't we call it what it is? It's an injury that we were on the front lines. We're battling something, and this is an injury as a cause of that battle. It's not a burnout. We're not, essentially displacing the shame on the individual from the institution. And I think a lot of it, again, comes down to this concept of shared language, where you're thinking something, they're thinking something, you both say the same thing, but none of it is what either of you is thinking. And you just keep moving forward. And that's what ultimately leads to these, essentially, situations of frustration that you see here. And so, sort of shifting from that, in 2019, ABC had this fellowship for Grey's Anatomy. And so I was for medical writers. So I was like, I'm just going to apply for it randomly. I applied for it. I sent they wanted a writing sample. I sent it. I interviewed with all those people, the executive producers, and they wanted me to go down there to help. So during my vacation times, I went down there to sort of help define this language, because I recognize, just as you see in a lot of the talks that Dr. Cook gives, social media and the media in general is very critical in our current time because it helps define language. Was it last week when Elon Musk, he bought Twitter, right? Why did he do that? Because it's an instrument of influence, ultimately. Right, so went to Grey's Anatomy, I know how many of you feel about it, but just keep it to yourself. But I was actually pretty impressed by a lot of the writers, because they attempted to take cases from medical literature that were sort of way out there, sort of like the outliers, because it's sensational, it'll sell, and sort of, put that on the show. My job as a medical sort of, medical researcher or whatever, I sat with the writers in the writers' room from 8 a.m. to about 6 p.m. And so they came up with the core concepts of the episodes. So like broken heart, they're gonna have this relationship, drama going on, someone's got a broken heart. Give us a case of like a broken heart syndrome or something that sort of corresponds with that. And sort of my job was to sort of corroborate that and essentially define the language. So all the medical language we would define, not the writers. They would just give us the script, and it would say, like, Meredith says medical, and they would have us sort of define that. And you can imagine, and I'm not kidding you, you can imagine if someone that doesn't know what they're doing fills that in, it can sort of influence public opinion when millions of people watch this show, right? So if you watch season 15 and 16, there's a disproportionate caseload of aortic disease. There's type A dissections, there's type B dissections, there's a thoracoabdominal there's TVARs, there's endo leaks, there's all kinds of stuff. But I use this to sort of not for the disease processes, but sort of target our patient populations. How many of us have patients with aortic disease, pathology, tears that come in with methamphetamine use all the time, right? So the patient in this case, you see, they're stenting at type B dissection, positive for methamphetamine use, and they spent a good segment of the episode talking about how she's still doing drugs and blah blah blah. And if that reaches one person and it prevents them or circumvents them from doing it, or a family member that helps guide them to a better direction or safer direction, that's a win, right? As far as our profession goes, professing advocacy for our patients. This was the case at that time when I was there. It was, if you guys remember, at the border there was this issue with the kids that were getting caught in cages, etc. And so this sort of helped reflect and sort of echo what was going on at the border. So we called American Red Cross, and sort of like I was telling you, they want the exaggeration. So we asked them, what's the longest number of days that a kid has been in custody there, without seeing their parents? And initially we wanted to say like 3 months, but they're like, no, actually it's been like 24 days or something. So we extended to 29 days just to make it closer to a month. But essentially this is the case of one of those patients, 4-year-old, sort of caught in the crossfire, in custody, has abdominal pain. They keep giving her antacids, ultimately was found to have non-Hodgkin's lymphoma, but it doesn't end there. The dad comes in, he makes just enough money to not be Medicare eligible. So, and then it goes through the hardships that patients like that face every day, that we see, in our patient population all the time, where they make just enough money to not get Medicare insurance, but they don't have enough money to pay for insurance, right? And so again, that helps influence policy, because believe it or not, a lot of those legislative aides, they're young, they're young, hip, they're at Starbucks, they're watching Grey's Anatomy, and this stuff influences them. So another thing that was affecting our sort of profession, which within the last 5 years, I would say, is the Ross procedure. And Dr. Kia can attest to this. We've had our run of controversy amongst ourselves and the cardiology team here. And this is a national thing where the pendulum is swinging. We're doing Ross procedures on younger patients for aortic valve stenosis. But defining the language publicly helps drive the policy, and sort of if a patient with aortic valve stenosis who's young sees this episode, they'll know that Ross procedure is an option for them now, and they're going to ask their cardiologist and hopefully help drive the care. And as you remember, the Black Lives Matter issue, there was an episode that showed that healthcare professionals were not essentially immune to institutional racism, and this was all happening, for the subsequent year, COVID happened, and as you remember, it was sort of a stressful period, and this is just sort of a raw reaction by Bailey when she faces a patient that says, I don't want to get vaccinated, and their hospital is highly impacted, their ICUs are flooded, there are people on ECMO, etc. And I'm sure everyone in this room can attest to having a patient like that, because we sure did. We had patients on ECMO who didn't want to get vaccinated, who needed to get transplant, etc., and they were not eligible. So, it's sort of, I think being involved in the media helps sort of define the language publicly, so we can advocate for our patients better, ultimately. And it doesn't need to be through Grey's Anatomy. It can be through, just Twitter. So that's me and Chief Bailey, and then one of my co-residents was like, oh, you need to put all this other stuff, so I did. So this is me making a prop for them. It's covered by the badge. The anesthesiologist didn't show up, so they asked me if I want to play the role, so I did. Turns out there's not much to it. You just stand around. But there was a period where this patient coded, and I bagged the heck out of him, and before I forgot that they're an actor. So so after that, I got kicked out of Burbank and came back to Sacramento. So ultimately, advocacy is telling people your story, the public, the government officials, because they don't know it. You'd be surprised how many times I go there, they don't know anything. They don't understand what we do every day. It's very basic stuff, and to hear it from us on the quote unquote front lines, it means a lot more than to hear from our legislative sort of steering committees. So, and ultimately, we know, and I keep repeating this thing, that the system is broken, but ultimately, what I've learned by going through Washington and to DC, etc., is, during these periods when we go, it's not just a time to sort of pour our outcry and sort of raise our voice, etc. It's a time for self-reflection into our specialty, into our field. Why has this been an issue for the past 2 decades? Why hasn't this been addressed, in a more imminent fashion? And then you realize that because the system is not, it's not that it's broken, it's flawed. To say that it's broken, you're implying that at one point it was a perfect fixture, but it never was. It's flawed, and it keeps recycling the same flaws in a vicious cycle every fiscal year. And until we sort of get involved and oil the gears of the direction we want the healthcare policy to sort of go, nothing's going to change. It's going to be the same lobbying voices, same money, etc., that are going to dictate it. This is me and Dr. Cook during one of the legislative advocacy days. So again, how do you do it? Collective voice. You make an initiative, collective voice. Meet with your members of Congress. You don't need to go to D.C. You can meet with your local, representatives, and essentially underscore the legitimacy of the issue you're trying to raise. Tell them it's affecting your patient. Call them. Send them a letter. And I have some instructions here, but and you'd be surprised. It goes a long way. I've emailed them and I've gotten responses. I've written a letter. I've gotten responses. And a lot of time it helps initiate the discussion. And then later they call you because they have an issue that comes up and they need a consultant, and you can help drive the ship essentially in the direction that you think is best fit for your specialty. So site visits, you can even invite them. They get really excited to come into hospitals, but COVID has sort of changed that. And social media, as we know, and Dr. Cook would tell you. So all of this is to sort of try to anchor some sense of sanity in this sea of like chaotic DC. But ultimately, advocacy for our patients does not mean just advocating for them in DC, in the state assembly, in your sort of local whatever HOA. It's advocating for them in the hospital, advocating for them bedside, advocating for them with radiology, with the consulting services, and making sure that they're getting the best care that you want them to. When I was reflecting on sort of the characteristics that we sort of, every time you ask a med student or when we were medical students, what makes a good surgeon? It's very hard to define that, to sort of come up with a core concept. I actually think it's becoming harder and harder as we sort of progress through our specialty, because we see more complications, we see more regulations, we see more issues, and some of those earlier virtues may not necessarily be make the best fit surgeon to navigate these tides. So yes, everyone thinks you should have good hands, you should have perseverance, resilience, hard work, or clinical judgment. But nearing graduation, one of the things Dr. Cook would always tell us is 9% of surgery is common sense. Yeah, and it really is. A lot of it's common sense, communication, humility, remembering that you're just a human being, and these patients are essentially vulnerable members of society at your decree, and with the social sanction to cut into their flesh and do what you need to do to save their life, and making sure not to essentially overstep your boundaries at any level. So humility is critical. Insight into yourself, insight into your field, and foresight. Foresight's something that's very critical. We always talk about in surgery. For oral bores, what if this happens? What do you do? What if you clamp the aorta and this happens? Then what do you do? That's all foresight. That's foresight that comes through experience. Then why is it that we don't have foresight in the political world? Why do we treat it like this void that's sort of isolated from our medical practice, when in fact it's actually influencing our medical practice, and it's intertwined in our medical practice on a day-to-day basis. I actually recently learned that bundle payments started with Denton Cooley in Texas. I never knew that. But that goes to show that these sort of legendary figures that were on the forefronts of our specialties, were taking these things into consideration. They weren't just really good with their hands. So foresight is critical, but ultimately all of it should be bundled in kindness and empathy towards your patients, because again, they're vulnerable. And I learned this early on from one of our patients. I think I was a second year at this time. We had a very high risk, multiple morbid patient with a high risk of mortality after essentially a bypass. But he was only like 37 years old, and I was the second year and I did the consent and everything. And after I was done, he called me back into the room. The nurse called me back and said that he wants to give this note to me. And on it, it said, are you going to be in the room? Because I need a familiar face. Then it hit me. He doesn't even care who the surgeon is. He doesn't care who anesthesia. He doesn't care who the anesthesia tech is. He needs someone to hold his hand, to support him, to be that sort of, the attributes that we profess to be within our profession, a helping profession, so to essentially walk with them through these challenges. So, and if we go into the OR and we fail, we exhaust all our tools and utilities, then we can at least, be shepherds amongst one another and as human beings. We don't need to continue this sort of an equal relationship, patient-physician relationship, as if we're sort of superior to them. We can just be a human being and sort of shepherd them through this. So, through hope, empathy, kindness, and clinical presence, in a world where the EMR, this sort of glorified cash, register is trying to drive us away from patients, it's very important to be clinically present for our patients and sort of profess our thing. And if we exhaust all our options, we learn that even in those situations, with hope and empathy, broken hearts can be mended. And this sort of drives into a sort of a different topic, stepping back from the political arena to the patient's bedside to life in general. Every life, if you think about it, as it was actually quoted by this Italian philosopher, Giorgio Agamben, so every life is a life that's exposed to death. We can't fight it. We're all driving that direction. It's a common denominator. And our resistance to death is that original testament or political element or resistance, right, to death. So the foundation of politics starts from the time that we're born, right? And what is the thing that sort of opposes death in our society? It's medicine. And who's the battalion? It's the medical professionals. It's us. So universal exercise of entropy. John, do you remember what the second law of thermodynamics is? Yeah, exactly. Everything goes towards chaos. And this question was not planted, in case everyone's wondering. So everything goes towards chaos, gradual decline to disorder and death. That's the second law of the thermodynamics applies to human beings as well, right? We all ultimately go to death. And as sworn figures to sort of try to circumvent death or fight death or battle death or be on the front lines of death or look death in the face and try to sway it a different direction, that puts us at a challenge. And, naturally, I think sort of our decree unites with Dylan Thomas's poem where he says, "Not go gentle into that good night. Old age should burn and rave at close of day. Rage, rage against the dying of the light." And it sort of conveys, I think, beautifully the role of medicine in fighting death. And this power struggle that we're facing, again, in the operating room, on the wards, in the ICU, with fighting this greatest, political force in life. Again, using our military metaphors, battle against COVID-19, front lines of medicine, etc. And it ultimately conveyed to me that as surgeons, the political act of surgery is not just to perform our surgical operations and master our operations and become masters in our sort of specialty, but it's to win the heart of the patients and to learn how to win the hearts of the patients, because it is only then that we can sort of win the patients and this battle against sort of ultimate decline. And that sort of leads me to something a little bit more personal. So my roots essentially stem from my dad, who was like a sort of an obscene academician. So he did general surgery, then he was bored, so he did thoracic, he did trauma, and then he thought, if I go to some rural area in the country, I want to be very comfortable doing OB-GYN, so he did an additional year of OB-GYN while working and studying forensic law. Yes, it's all true. I've seen the certificates. He actually did his thesis on esophageal cancer in Iran. It was the first paper that sort of defined the epidemiology of esophageal cancer and its relation to hot drinks in Iran and the northern region of Iran, especially where they drink hot tea. If you read textbooks, you always hear China and Iran, northern. They didn't cite my dad, so that's a problem. We're gonna have to talk to them. But the original study was done by him, and I have the paper to prove it. So this is just a quick background. Within the past year, we sort of faced a challenging time. He was diagnosed with pancreatic cancer, and he was treated here by Dr. Bolt, had a Whipple, survived chemo, was negative, and sort of at this point, his sort of behavior defined that role and that fuel of surgeons that I see only as a calling and not a job. After all that, he went back overseas to do pro bono cases because he was like, what am I doing? I'm wasting my life. I feel up for it. I'm going to go see at least patients in clinic. I can do something, put myself to use. And that's exactly what he did. He did that for 4 months despite all our sort of, bickering, and ultimately had, unfortunately, recurrence and passed away here about a little over a month ago. This is a video that one of his colleagues sent me from overseas. It's in Farsi, but I translated. It was actually made for Doctor's Day over in Iran last year. So there's translation that hopefully it works.
ما همیشه در نظر داشته باشیم که حرفه ما حرفه مقدسه، حرفه ما مادی نیست. ما در اصل باید حکیم باشیم، طبیب باشیم تا یک شغل درآمدزا و رابطه مادی با بیماران احساس نکنیم. سعی کنیم بیمارانمون رو بهبود بخشیم از نظر جسمی و روحی و تا اونجا که امکان داره دست فقرا بگیریم، تا اونجا که امکان داره دیدگاه مادی روی بیماران نداشته باشیم انشاءالله.
So, and that's sort of, that's not something that's at the end of his career. That's actually the decree I was raised with. I remember as a child, on his office door over in Tehran, it literally said, and he was in one of the better areas of Tehran, so there's a lot of traders and well-off people that came and were his patients, but it literally said no one's turned down if they don't have the money, and he would pay out of pocket for not only their surgery but their hospital stay, and in return what we found was a lot of the traders and people that had more money would double or quadruple or pay a lot more to sort of help with that. That's sort of a charitable sort of situation. So the both classes of individuals were getting the sort of equal care in essence, and people weren't turned away to another hospital or to a county hospital. It's and it at its core, it was in principle following the decree of medicine and professing what we profess every day or claim to profess. So I hope to follow his footsteps. There's this was a poem that sort of that I came across that sort of reflects how I feel, but your absence has gone through me like thread through a needle. Everything I do is stitch of its color. And I hope that I can sort of follow his footsteps and his decree and his direction in our specialty and in the field of medicine as a whole. Next, before I thank anyone else, I want to thank Dr. Bold. I don't think he's here, but it's because of him that my dad had an additional 12 months, and me being an over 40-year experienced surgeon, he was very hesitant to do a Whipple. He talked to Dr. Bold in detail about what suture he's going to use for this, and Dr. Bold had to really reassure him that the outcomes have improved significantly since the times that my dad did the Whipple. Whipples and esophagectomies were the two surgeries that he stayed away from in medical practice, as all of you know, for good reason. He was a high-volume surgeon. So I want to thank Dr. Bold for essentially giving me that additional 12 months. These pictures that I have here are all from the time of surgery to essentially 3 months ago, and none of these memories would have been possible if Dr. Bold hadn't, operated on him. This is him as a typical surgeon. After his Whipple, this is day one. He did about 12 laps around the unit, and he was asking me, he's like, why are they making me walk? They didn't amputate me. They didn't operate on my foot. What is this? And he was like trying to throw it at the PT or something like that. Just use it. So then he started using it to walk with it. And then, of course, my wife, who sort of went through all this with me the past 6-7 years, but she didn't just go through it with me. She went through it with me, my family, 2 beautiful kids, and graduated law school, California bar, and is a full-time practicing health law attorney. So, and in the middle of this was like offloading a lot of, emotional issues for me when I was at work. So, when we think about quote unquote burnout or moral injury, mine is nothing compared to what she went through. And for raising our kids essentially to have those same values, this is my son Zane. He wrote this in school, and we don't talk about this stuff in front of them. And he said, my father is my hero because he helps my grandfather, or grandpa. I love him. And I thought he was going to say because he's a doctor, right? That's a natural direction that we go. But again, redefining the language. And my mom, unfortunately, I couldn't find many pictures of her smiling within the past 12 months because of the unfortunate circumstances. John? And finally, just thanking, Dr. Rodriguez, all my mentors throughout my training, Dr. Pevic, Boyd, Young, many of whom are not here today, but had a great impact on my training and on my outlook into medicine and the language of medicine early on. As Dr. Pevic always told me, you need to get rid of those bad habits early, and he's right. And everyone else, on our team, none of this would have been possible without everyone from clinic staff, from OR staff, ICU staff, our step-down unit, the EVS workers, everyone, with the exception of transportation, because they're always giving us tickets for no reason. I'm very appreciative of everyone in this institution. And, I remember there was a resident here before me. I don't know if you guys remember him. It was Adam Myers. I don't know if that rings a bell. But I remember my 4th year, he saw me and he's like, "You're going into your 5th year of CT surgery. Why are you still smiling?" He saw me in the hallway and I was like, I don't know. Am I supposed to be angry or something? But, I sort of reflected on that. And in the past 12 months, my grandfather died in our ICU. My grandmother died. My father passed away. And, all within 12-month period. And, you just keep pushing forward. And what I realized is, when things get out of control, and that's the general advice I'll give interns and other junior residents, when things get out of control in your life, at work, just focus on what you love right under your nose. And these people you see in this picture were what I loved. I loved coming to work. I loved operating. I loved working with them. I truly enjoyed it. People ask me, how many more days do you have till residency? Do you have a count? I really don't, believe it or not. And my wife was asking me last week, and I was like, I really don't know how many more because I love it. Maybe I'm indoctrinated, but I love it. Also our patients, Dr. Kiai, everyone. So just going to end it with this, about my journey through residency. What's more important, the journey or the destination? Ultimately, it's the company. And it's been a pleasure being in the company of you folks and learning from you and just advancing in my field. And I'm very humbled and very appreciative, and I thank you all.
Thank you for sharing not only that uplifting and inspiring journey, but also those personal elements that make each of our journeys unique. And you sort of had the crash course in this last year of the intersection of why what we do is such a sacred privilege.
Right.
And thank you for
Truly
sharing
is.
that.
Truly is. Thank you.
For all of us.
Absolutely.
So with that,
I got to answer this page.
No, don't get out there easy. What is your plan, my friend? So
next year, I was actually recruited to Sequoia Hospital in Redwood City to their adult cardiac surgery program. For you, those of you that don't know, the cardiac surgery program, you might probably know this because of your UCSF, but the cardiac surgery program there was started by Dr. Fogarty, who left after he left Stanford, and it was followed by Dr. Gaudiani and currently Luis Castro. So I'll be trying to fill big shoes, essentially, following their footsteps.
In a beautiful place.
Yeah, it's a nice place.
Thank you. Again, anyone want to talk to, has some questions? We do have a few minutes. This issue of advocacy is a big issue for all of our societies, American College of Surgeons, as you,
Right.
the Surgical Coalition, can we be stronger together? And the moral injury. I think Dr. Jerkovich, has spoken about that and written about that in many ways. And this is an important and complex part of what we do. Dr. Cook.
So Amir, congratulations. It's proud to see you up there on this stage after 6 long years. And in addition to as a visiting medical student on our service, there's a lot of, you've sort of outlasted a lot of faculty that's been here as well, but they are here with us, perhaps on Zoom because they got the email and in spirit. One sort of, if I could ask you to comment, since you're really an expert on sort of advocacy, specifically the role of the Political Action Committee of our surgical specialty societies. And, as we become leaders within these specialties, we are asked to motivate the people on our committees to contribute to the Political Action Committee, or the PAC, right? And I get this question all the time, and you probably have a understanding of the methodology in the actions. If I am on one side of the aisle, why would I contribute to a PAC that works with both sides of the aisle? And also, if I took the political contributions of our alphabet societies as a snapshot one year, it might be a little bit skewed to one side of the aisle. And there's a methodology why that is. Do you want to comment on that?
So when you're saying it's skewed on one side of the aisle, you're talking about essentially partisan politics, or?
No, well, it's on from the alphabet societies. It's not partisan. There's a strategy.
Sure.
But if I'm just taking a snapshot, I'm a lay person. I might say, oh, they're giving to a particular party.
Yeah. It's actually interesting because a paper was recently published, I believe, last year about this, and it listed all these societies that essentially have made declarations against gun violence and gun, and it went through the contributions that the political action committees of each of those societies has, and all of them were contributing to members of Congress who were voting for essentially freedom of rights for gun. So it's sort of that paper outlined this sort of almost like collision between ideas. But I think what happens, from my understanding and from my experience, is each year the Political Action Committee, its steering committee, comes up with some main issues that are going to be facing our specialty within the following year. And a lot of time, it's the ones that get the most attention are the ones that have sort of, monetary sort of, involvement. So like the 8% cuts. And the ones that get the least attention are like the resident shortages, et cetera. But that's usually how it happens. And that's sort of spearheaded by the president of the society. They're very involved in sort of the steering committees to define what is going to be the battles we're going to try to fight this year, and what are the battles that ACS and other societies are fighting, so we can sort of find the perfect, road between all of them to make one of these a win. Because as you know, and as you heard, it's very hard to win in Congress. You're constantly trying to win each battle each fiscal year, but you know that it's going to become a recurring issue.
And also, from my understanding, they look at the makeup of Congress each year, and that kind of steers their contributions. So that's why, in a snapshot, it might seem that they're favoring one party, but in reality, if you look at every year, they're scoring on the makeup of Congress.
Right. Yeah, absolutely.
Because it does, as you say, take both sides of the aisle to make any
push things forward.
Push things forward.
Yeah.
So I do think that, and that's a constant challenge for our society.
Unfortunately,
to advocate for making sure that the patient is at the center.
Right.
How to get it done.
Exactly.
So, what is your thinking about your future in political action? Are you going to get involved with the college, the STS?
Yeah, I'm actually I'm going in September back for legislative activities in DC. But I'm going to continue. It's something that I've been passionate about. Sort of policy making is something that sort of, like I said, I think, from early on, I wanted to make an impact, and law was the field I was sort of, gravitating towards. That's why I work in car. But I felt like things were so slow. That's why I went to surgery. But in the surgical field, there's such a big void because, unfortunately, our colleagues are not as keen into getting involved because they're almost scared. You know, they don't know the language, they don't know, and they don't want to get involved. So it provides this perfect sort of opportunity for those that are interested to step up and sort of lead.
You know, we've talked before about the fact that here in Sacramento, we have a unique potential to kind of train young people in this language.
Right.
Just like anything else, it's a language.
It's a language.
You need to learn to get the job done, and so you really have helped pave the way. We've had a few other folks.
Yeah, Lexi, and yeah, absolutely.
Who've been involved in this long going, and I think it is a great legacy.
Yeah.
So I'm glad to hear you're doing that. You have lots of colleagues involved in many of these societies and specialty organizations that can help you. Let us sponsor you.
Absolutely. I appreciate it. Thank you.
Thank you so much,
Thanks.
and we wish you all the best.
Thank you very much.
And
Thank
you're
you.
not done yet.
Am I done?